Thank you, Mr. Chairman, for the kind words. And we will present here the initial experience of transcolonic nodes back in Brazil, in Rio de Janeiro. And this is my disclosures and the main author disclosures also. And in terms of transcolonic nodes, we can read as follow, beginning in 80s with the experience of Buis, and you'll go to 07, 08, 09, and you can see authors like Lacey, Bougard, Leroy doing transvaginal assisted cases, and Sila in cadavers in 09, just following with the initial clinical experience. So now Zorron and these groups presented. And we can see the flow, what is going on in colorectal nodes from the concept, initial things in 2007, cadaver anatomy studies in 08, testing clinically in 09, also clinical in 09, and the evolution we will show you, gentlemen. This should be highlighted that this study have an IRB approval by Rio de Janeiro City. And that's the technique. So we dissect just over the pectin line, and then we pass a flexible scope or a rigid scope, and the intention is to achieve a total mesorectal incision by mailing two techniques or two approaches. One is flexible, meaning that the flexible scope will pass through the orifice that we create, and we will use CO2 and air, also with monopolar instruments to dissect all the mesorectum, and a three-trocar technique with laparoscope will allow to liberate the colon to mobilize it. And the other technique is to use standard rigid instruments with a special platform, and one of the device that's already in the market use it as single port, and the intention here on that approach is to use rigid instruments to dissect. And as we can see in the video, will be more illustrated. So that once the orifice is created laterally, and this is the diagnosis colonoscopy, we go on the posterior wall. As you can see here, the displacement of some proctoscope and preparing. And very interesting here that you use your scope to visualize it better. So once you grant access to the perirectal space, you pass the scope and you start insufflating CO2 or air, and you can see here with endoscope images. And lots of the dissection will be achieved just by air or CO2 distension. And the instrument have the intention here to be blunt and identify vessels and ligate it. So in that case, flexible, you're using a flexible Caesar monopolar made by Apollo. And we can see here how we can clearly see that we are leaving the rectal external wall and dissecting. And on that image, we are seeing transilluminating, and we are seeing the abdominal cavity, and are about, as we can see now, just getting to the peritoneal cavity. So this is the final inspection, and then the laparoscopy begin with 3 5mm trocars or 110 in umbilicus is done, and the dissection, ligation of the vessels. And we can use clips or whatever. In that case, was a sternal knot was preferred. So the dissection, and here we can see how freed is the colon, and we can see here how much of a dissection we had achieved previously with the endoscopic approach. So cutting the colon, you can see here the marginal, the part marginal, and we're going to pass the colon through the anal channel, and we can mobilize, as you can see here, a lot of And mechanical anastomosis with circular stapler will be built after that. So we have here the image, and this is a stapler. And we're going to see the last image of the external image of the abdomen in the field. So we can see here, this is the external image. And we can see here the first case, 2 cases with flexible scope and 3 cases with rigid scope. 1 case was converted due to open surgery because it was a very big, very large tumor that was unable to be done even by laparoscopy. The operative time was longer, 310 minutes specifically because of the conversion case, and there's a very good outcome in terms of pain score, 3.4. So in conclusion, transcolonic nodes is evolving in an attractive application that we can use for colorectal surgery, and future technology improvements will really make it easy to us. And this is our research team in nodes. Thank you for the attention.